common causes and clinical presentation of brain injury. And I'm going to touch on evidence for management. And when I'm saying management, I don't mean specific treatment strategies. I'm talking about care settings. So it's simply raising the importance of how we should evaluate our own work. There will be some challenges to in the existing evidence to what we are used to do, and there may be some gaps in research that we need to address. And I'll finish off by just setting the scene to Dave, who kindly agreed to share his story with us, one of our patients. We walk around carrying this organ in our heads. And arguably, it is one of the most sophisticated, most complex objects in the universe. We struggle to understand what is going on there. And this has been a struggle for humans for many, many, many years since the beginning of history. This is the organ where we think, we laugh, we love, we hate. But yet, we are struggling to understand the brain using our own brains. So it's like our brain is too inadequate to understand itself, or it is too complex to be understood. About 6,000 to 7,000 years BC, people started to drill holes in their heads when they had headaches or had some form of madness, and they thought this may cure them. People thought that the heart is the center of the heart for many, many, many years. Even ancient Egyptians, when in the process of mummification, they will reserve the hearts very carefully, but actually they thought this was just a bit of junk in the head, they don't need it, and they will scrap it out of through the nostrils. They gave it a name, but nothing more than that. Till the time of the Greek, and they started to say, probably there is some function, but still they thought it was only something that we use as a radiator, just to get rid of excess heat, body heat. Herophilus came along 300 years before Christ, and he started to do sketches and dissect dead body, and then he started to think probably this is the center of our bodily functions. Lots of milestones, when you read those, so fascinating. People focused in one area on neurophysiology, EEG, and they thought probably this is the way of communicating with one another, and they talked about telepathy, and they thought that this electricity going in our brains is to do with this. And then you have an era of neuroimaging, structural and functional imaging, and now it's getting really amazing to minute details of the brain. It makes us wonder whether neuroanatomy that we studied in our college days was actually anywhere near the truth. We have the behavioral scientists. They started to talk about what matters is our behavior, not necessarily the structure of the brain. And we also have the psychoanalysts who thought that probably what matters is the early childhood experiences and our instinct and urges. And now people started to try and integrate all those and thought probably there's something else going on. And you hear those weird and wonderful talks about neuroscience of ego or neuroanatomy of familiarity, and things that you don't think that they will come together. But one of the most and the greatest educators in the field of brain function was actually the brain injury itself. So we learned quite a bit from the brain injury. You will have heard of some of those names. Phineas Gage is a railway worker who was quite hardworking, polite, courteous gentleman, 25-year-old. And one day, this was in the middle of the 19th century, he had a horrible, bizarre accident. He was just setting up or helping out in setting up a railway road, and this metal spike went right through his cheek, out of his frontal lobe. He didn't even lose consciousness. He sought some medical help, and amazingly, he survived. But he survived as another person. He became very disinhibited, irritable, rude, aggressive, and people start to wonder whether there's certain parts of the brain actually is what makes us what we are. And this is probably the frontal lobe. So frontal lobe is actually where we live. This is our personality. This is what we love and what we marry. It's just this frontal lobe that will make us what we are. And clinicians will be very familiar with this. You come across patients and you see the parent or a partner saying, they look so much like my son, but actually he isn't my son. Just the outside appearance is similar, but it's a different person. A few years after that, Broca is a French surgeon. He started to look at the part of the brain, but actually this just happened to him because he was looking after a patient who lost his speech. And this patient started to only say one word, tan. And even they gave him that nickname. After he died, he looked at his brain and he realized that there was a bit of brain damage in the left frontal area. And then they started to think, neuroscientists started to think, probably this is where the speech is. And we were all familiar with the Broca's area, where the speech is formulated, expressive speech or motor speech. Similarly, an Irish doctor, in 1919, First World War, he started to examine over 2,000 soldiers, and those soldiers, afterwards, they died. And he was particularly interested in the back of the brain, the cerebellum, the brainstem, and the occipital cortex. And then he started to realize and give this a name that is the visual cortex, although it's counterintuitive because you have the eyes in the front and the visual area in the back. But obviously there are some embryological explanation to this, why we develop in our mother's womb. HM is a case that will appear in lots and probably every psychology textbook. His name was only revealed in 2008 when he passed away. This gentleman had a fall when he was 7 years old. So this led to epilepsy. His epilepsy was quite resistant to treatment, to the extent that early, while he's still a young man, he had to retire from work and live at home. This prompted a very enthusiastic neurosurgeon who said, okay, let's get rid of those bits that may be causing the epilepsy. So he surgically removed his hippocampi and amygdala and the parahippocampal gyrus. This is like right in the, within the temporal lobes. And actually, he cured his epilepsy. But this was at a very huge expense. He had a problem, a horrible problem with short-term memory. So he wouldn't remember things, day-to-day stuff, but actually, he gave us insight that there's a difference between what we call declarative or procedural memory, declarative or episodic memory as opposed to procedural memory. What I'm talking about is, if you teach him how to drive a car, he will remember how to drive a car with practice, because this becomes an implicit procedural memory, but he wouldn't ever remember that you ever taught him to drive a car. And the function of the hippocampi in terms of consolidating short-term memory into long-term memory became more obvious, thanks to Mr. Molaison. Clive Wearing, again, you may have come across this. Has anybody heard his name? Yes? Yeah. He's an outstanding musician who was in charge of the BBC 3 at the time of the royal wedding in 1981, Princess Diana and Prince Charles, when they got married. He was in charge of the music at that time on the radio. He is very talented. And what happened is, shortly after that, in the 80s, he was one of million. I mean, the chance of developing this herpes simplex virus is 1 in a million. So he was pretty unlucky. And he had a problem with the hippocampus as well. Those got damaged. There are some amazing videos out there, and I would really encourage you to go and have a look. This guy, his whole life will last for about 30 seconds. According to his wife, after between 7 and 30 seconds, he will remember things. After that, he can't remember anything. So he's living in a state of wakening all the time. So he will have a diary and write down, now I am awake. A few seconds later, now I am fully awake. Another few seconds, I am really, really awake. And then when he looks back in his diary, he can recognize his handwriting, but he can't really remember that he's ever done that. He feels that he can't remember any of his what happened to him in the previous days. Every time he sees his wife, he greets her amazingly because he hasn't seen her before, or hasn't seen her for years and years. It's just so amazing. You can imagine if you are waking up from a terrifying dream and you're so confused, who am I, where am I? And he's like that all the time. And things will disappear from his memory just like that. To put things in figures, in Britain about 1 million people a year attend hospital due to head injury. 120,000 suffer from long-term effects of severe head injury in the UK at any one time. This will make it about 100 or 150 disabled survivors per 100,000 population. Some studies will say it's 200. One family every 300 is affected by the long-term effects of head injury. In the States, they spend quite a lot of money on brain injury because of the nature of the condition. It's not really an illness. It's just something that we are all to be blamed for with the civilization and driving and the road conditions, etc. Those figures came right down in the early in this century because of the, again, better and safe driving conditions. About 2% of the USA population live with head injury-related disability. The peak, as you know and you will have heard, of brain injury will, and I'm talking about brain injury now, head injury now, so it's a traumatic brain injury, will be between the age of 15 and 29. A smaller peak over 65 due to falls. Lots of causes, mainly males are more affected, quite understandably. And you have road traffic accident as a big offender, and you also have the falls, which again is causing a lot of this. 90% of patients with severe head injury will live with what we call hidden disability. So you see people and you can't really figure out what's wrong with them. I have patients who are bodybuilders and they look really, really well, and my ego gets this small when I see them, and then they say, I can't go to McDonald's with my little daughter because I will lose my temper if there's any delay. They can't really drive, they can't work, they can't time manage, they can't prioritize things, they can't plan their day, they get very stressed with minor frustrations. But the trouble is, physically they look fine. So we talked about head trauma. Just a few words on the pathology. What happens when you have a traumatic brain injury? When the brain starts going on a speed and then it stops, then there will be oscillating movements within this confined space. So there will be quick acceleration, deceleration, rotational movements, which will lead to axonal damage, diffuse axonal injury. That is the small units of the brain that are called neurons. Those neurons will struggle to communicate with each other. And there are trillions of those communications and electric signals. But they start to struggle with this. And this is what we work on when we start the rehabilitation process. Arguably, those some of them can come back, although the brain tissue does not regenerate, but the communication between the neurons may actually can be optimized. So you have this injury, again, at the very time of the impact, despite seat belts and airbags and everything, still you can have this. Frontal lobe will be hit against the skull wall here, and frontal lobe is quite vulnerable in this. Then, like any other tissue in the body, you have bruises, you have swelling, and the brain doesn't have much space to swell. So this will cause even further injury. The bleeding that is caused, again, will press on the brain tissue, cause further damage. But more importantly, when you have a bleed, you have spasm on the arteries or the blood vessel that is actually that was injured. You have what we call cheese cutter effect, which is some of the blood vessels will be well tethered and they will cause injury to the brain as the brain moves along. 1 or 2 weeks after the injury, you also potentially could develop more complications. You can have what we call obstructive or post-traumatic hydrocephalus because of the scores. So the pressure within the head will keep increasing. You could also have chronic subdural hematoma. If you fractured your sinuses, the germs in your nose may have access to the brain. You have brain abscess, you have meningitis. So lots of things happen in the brain, but sometimes they happen in silent areas that you can't see any physical effects. We can't afford really overlooking other causes of brain injury. So subarachnoid hemorrhage is not uncommon. You can have traumatic subarachnoid hemorrhage, you can have spontaneous hemorrhage in your brain. And when we say subarachnoid hemorrhage, the arachnoid bed is one of the layers of the brain. So just under that layer, you have a collection of blood. Again, this usually happens due to an aneurysm. At the very bottom of the frontal lobe, you have the circle of Willis, so something may rupture, or the actual aneurysm can cause pressure. Leaking congenital anomaly, arteriovenous malformation, can also lead to this. The medial temporal and medial frontal lobes are most vulnerable, and that's why you have lots of psychiatric problems after subarachnoid hemorrhage. And people may need some surgical intervention. Hypoxic injury, this is when you have a heart attack and you survive that, or you have carbon monoxide poisoning, drowning, choking. So the brain starves from oxygen for a few minutes. The brain is really dependent on oxygen. So the actual brain is about 2% of the body weight, but it consumes about 20% of the oxygen that our blood carries. So if the blood supply is cut, this leads to tissue damage. And again, the beds that are most affected are the beds that have the highest metabolic rate within the brain. Again, the hippocampus, gyrus, basal ganglia, and this would lead to predictable consequences. Similarly, hypoglycemic injury can be accidental, insulin overdose, or can be deliberate, as a suicide attempt. And that's why, again, taking psychiatric history is quite important, because it may have actually led to the brain injury, not just as a consequence of the injury. The alcohol and thrombotic strokes. I touched on encephalitis already when I talked about Clive Wearing. I talked about herpes simplex encephalitis, which he had, but also more commonly than herpes simplex is when you have the pathogen or the organism you can't identify. So it looks like viral encephalitis, but you don't know what's going on. You don't know what the organism is. Alcohol, again, it has been well studied, and probably this is not the subject of the talk, but it can cause, obviously, cerebellar damage, can cause frontal lobe atrophy. This is frontal dementia related to alcohol. You have the amnestic syndrome as well when people have only amnesia, so just memory problem, nothing else is affected. Within the medial temporal structures are affected, mammillary bodies. Obviously, you have the metabolic effect of alcohol as well. So if you have a liver problem, so you may develop what we call ammoniacal encephalopathy. So the brain will suffer due to liver's inability to get rid of toxins. So you have a protein-rich meal, and then your presentation will get much worse. Thrombotic stroke, again, it's well studied. It's attached to, it's been linked to dementia, multi-infarct dementia or vascular dementia, although they're not the same really. It's a very precise injury. It's a bit similar to penetrating injury, head injury, when you just develop a small part of the brain will be affected in certain penetrating injuries, because with polyps, for example, you have the oscillating effect as well. So clinical features will range from physical effects, cognitive symptoms, emotional and behavioral problems as well. So physical effects, you can have dizziness, you can have epilepsy, 35% of people with penetrating brain injury will develop epilepsy at some point, as opposed to 1% in closed head injury. You may be really tired, and this is a big problem really in people with brain injury. They are less able to do things. 65% of people with brain injury will develop severe tiredness, very disabling tiredness. People may have some visual problems, hearing problems, numbness, weakness. So we have a range of physical problems just out of brain injury, let alone if you had other injuries during the accident, if you had an accident. Cognitive symptoms and behavioral symptoms are arguably much more disabling. So usually families are able to cope with a physical disability or involuntary movements or whatever, but when it comes to this combination, especially the behavioral bit, people will really, really struggle. So cognitive problems, again, vary from memory. People, if you have a right frontal lobe injury, you may have a problem with autobiographical memory. So you got married and got divorced and then got remarried, and you can't remember which one came first and what happened. And I mean, there was a patient who really appreciated his first wife. He loved her so much because this is what he remembered. He forgot the nasty bit before the divorce, and he forgot that his current wife is the most caring person who's next to him, and to him, she's a stranger. So as you could imagine, when somebody forgot that they retired, and how upsetting this could be. You have a problem with language, visual spatial skills, understanding other people, expressing yourself in terms of language, finding your way around, all this in the cognitive domain. Emotionally, you may have anxiety, depression, some other psychiatric problems. Either a formal psychiatric diagnosis can be made as in like a full-blown psychotic episode or schizophrenia-type illness, or schizophrenia-like illness. Or you can have just isolated symptoms, irritability or impulsivity, which again lead to the behavioral problems. People who can be quite aggressive, can be quite challenging, or they may be apathetic, and they may develop what we call abulia, where people literally means lack of will, so they don't do anything at all, which again, to some carers is much more difficult to deal with, even more than the aggression bit, because somebody's sitting on the chair doing nothing, literally nothing, and they're not depressed. They're just looking through the TV for like 17 hours a day. They don't want to go wash or have a meal or go out or do anything. So why does brain injury increase the risk of psychiatric disorders? It can increase the constitutional vulnerability. You can develop potentially, I mean, or arguably, you could develop dementia or a psychotic episode even years after the injury. You're less able to adjust to life changes. You have low frustration tolerance. But with the brain injury, there's another package of stressors. You lost your role in the family, and you lost your financial status, employment. You're not able to keep a serious relationship for long because you can be quite demanding or self-centered. With the physical disability as well, people will struggle sometimes to live with the new body image. If they have a scar or you're missing a limb in an accident, but even just with the brain injury, if you're walking with an abnormal gait, all this can lead to quite a distressing emotional reaction. Altered appraisal of the world. What I mean by this is when you can't remember things. Again, as I said in the autobiographical memory, this can lead to you misinterpreting what's going on around you. So you find yourself in a hospital, but you are a decent manager somewhere, and you don't know what they're doing with me, and they don't want to let you go. You will have come across the hemi-neglect bit, which is quite an interesting thing. You have a parietal lobe injury, and you don't acknowledge that you have a left side at all. So you put on one sock. You put on one sock, you shave one side of your face, you eat only one half of your plate, and you totally don't appreciate that there's another half of the world around you. So people may become very aggressive, and when you look into it, you realize that people are not really that aggressive. It's not a personality thing, but what's happening is every time somebody will just appear in the visual field like that because they can't appreciate this bit, and obviously they react quite aggressively to this. When people are unable to understand what others are talking about, they may interpret this as there is a problem in that person, and they're talking in a mysterious way, and they might get paranoid. Equally, they may be talking nonsensically, and they don't appreciate that. They think they're talking fine, and they don't know why the world is reacting like this or making fun of this or not being tolerant. More importantly, really, is the nonverbal communication. When you have a problem in the parietal lobe, especially on the right side, you have a problem with picking up cues in people's faces, body posture. You struggle to understand irony, sarcasm, humor. So just imagine that you take everything literally. So when I say these are the fire exits and this is time to panic and I'm smiling, I hope I was, you take it as a joke. But if I'm saying you've got to panic now, and then this can look really frightening because you are not able to interpret this. So if you're not picking up those cues, and equally, if you're not able to make those changes in your voice intonation or your body posture or body language to express a certain idea, then again, you look quite flat and lacking in animation, and the world will respond in a similar way to you, and then this will upset you. If you're not aware that you're becoming very self-centered and very inconsiderate and very demanding, then you will continue with this, and you don't know what's wrong with my partner. She can't cope with me now, and she should be. I just had a brain injury. And because you lack that mechanism in the frontal lobe where you can revisit the plans and monitor what you get up in the morning and you start your car, it's not starting, okay, I need to think of an alternative plan. I need to get the train or whatever. So you're not stuck in one mindset. But when you lose this, you're less able to appraise your own behavior. People may struggle to identify certain objects because they can't recognize the object, especially if there's something that you don't use very commonly or it is presented in a unusual orientation. So you're seeing it from the top or from a funny angle. Then they can't interpret things, and again, this can lead to some even psychotic reaction if it is quite persistent. In complex partial seizures, you have a dreamlike state, you have some hallucinations, and this can again alter your perception to the world. I already touched on the emotional reaction expression when you have problems either expressing those or interpreting others. Now, in the last few minutes, I'm going just to touch on this. This can be fairly dry, so I don't mean to present evidence, really. The point I'm trying to make is sometimes it's really, really important to be able to pause and think, why are we doing what we're doing? The fact that it's so obvious isn't good enough in these times, really. We have to justify this to ourselves, to our patients, to our managers, to our commissioners. What sort of outcome are we aiming for? I remember when I was trainee in one of the educational time I had with my consultant, she asked a question, I presented a case, and I said, yeah, this patient is depressed. And she said, what should you do to the patient? I thought, that's great, I know this one. You give them an antidepressant. And she said, okay, why? And I said, because they're depressed. And this is what you do. If somebody's depressed, you give them an antidepressant. And I thought she's being a bit difficult. But actually, it was an eye-opener, I have to say, because what the point she was trying to make is the fact that somebody is depressed and you have something that people called an antidepressant, you have to have a good evidence that this chemical will work in this particular patient with this particular set of circumstances, alcohol, drugs, this age, head injury, whatever. So do you have evidence to support that this drug works in this patient and will make them feel better? Oh yeah, the drug rep told me that, but this is not good enough, really. You have to appraise that evidence. You want to make sure that it's true and it applies to this particular patient, not just overgeneralize some research findings. And also you have to take into account things like placebo effect or the fact that people will get better anyway. They wouldn't remain depressed forever, usually. So it's really important that this is just an important introduction, because some of the findings may sound a little irritating when you look after people with brain injury, they will get better. It doesn't automatically mean that you are doing something good. We have to think about it. So this is just the normal pathway. I'm sure you're all familiar with this. You had a bang on the head, you go to A&E, and then neurosurgery or whatever, then a bit of rehab, and then you return home, hopefully. Or you may need some rehabilitation, you may end up in a residential home, or you return to functioning. So we need to think about this algorithm. Why is it important? Because you have different problems in different patients. People may be presenting only with physical problems as opposed to neuropsychiatric problems. What you use in an acute setting will be different from what you use in terms of treatment strategies in a chronic setting. So somebody is still confused in what we call PTA or post-traumatic amnesia or acute confusion state. The treatment is to manipulate the environment, to be friendly with them and familiar and take them to a domestic environment and keep medication to a minimum. But sometimes it's very difficult to achieve this in a busy acute neurosurgical ward. But this is particularly important in the acute phase, to keep medication to a minimum so you give the brain a chance to recover. Giving medication to calm people down and pretend that you're helping them, we're not really helping them. We're helping ourselves, helping the system, keeping other people safe, or at least filling the gaps in the system. But we have to be clear on this. But this is particularly important in the acute. It's still important in the chronic phase of the illness, but it's more important in the acute. Treatment will range from pharmacological or psychological, psychosocial interventions. So we need to evaluate this when we give medication, when we use CBT. Certain symptoms are reversible. Somebody is depressed or having sleep problems, they would benefit from something that will take the symptoms away. But we don't have to be aiming all the time in taking symptoms away, because sometimes we need just to call upon what's left in the patient. If they have a memory problem, they can rely on language and using reminders and calendars and what have you. What I'm trying to say is sometimes we need to make that distinction between cure and rehabilitation, living with the disability and making the most of our lives. There are certain things we should do to patients, but not everything we should do to patients. Sometimes we only need to work on the environment or our own expectations or family's expectations. So this was based on a fairly recent Canadian review, evidence-based review on acquired brain injury, moderate to severe acquired brain injury. So I'll whiz through this very quickly. Levels go like this. The strongest is level 1, the strongest evidence, because you may have an evidence, because if I say to you that I give my patients carbamazepine and they get better, it's an evidence, but it's very weak. It's just my opinion. It's still an evidence, but it's not that strong. But you need a randomized controlled trial to verify this. So when you see this between brackets, this is what it means. So patients cared for in a specialist setting with dedicated staff will do better. And we need to think of resources when we look after people with traumatic brain injury at the severe end, because they will cost more. So as I say, I'm just trying to give you a feel of this. Inpatients still can help, especially with mobility and self-care. What we do during the inpatient setting, whether it's single disciplinary or multidisciplinary, does matter. Because again, we have evidence and that the intensity of inpatient, what you do during this inpatient stay will matter. And this is level 1 evidence, which is the strongest. Again, the intensity of therapy will predict motor functioning but not cognitive gain. So we can't afford having a blanket approach and do this and it will help everything. We need to be targeting certain symptoms that we think would be most helpful for this particular patient. There is a reciprocal relationship between cognitive function and community integration. The earlier you get in, the better the outcome. Again, it appears quite common sense, but we need to make sure that this is there's evidence for this as well. Certain patients may, if you have a limited resource, then you need to target patients who will have the best outcome, or they will benefit from this particular intervention. And again, there's evidence that if you are younger, you will benefit a bit more. Not being ageist, but this is the evidence. We know that you do this particular intervention to this particular age group, they will get better. You do the same intervention to older folk, they may not benefit as much. So we need to bear that in mind and work based on that. Certain occupations, again, may benefit a bit more. If you have a bit of a flatlet or a house attached to your ward, this will help a lot. Outpatients and the community. Again, multidisciplinary is quite important. Should you do gym at home or do you go to a fitness center? again, there is an evidence that there is no difference, for example. So it's quite important. And obviously, not having an evidence doesn't mean that it doesn't work. Just it means that we need to work on either identifying an evidence or proving that that this is not helpful, this particular intervention. Communities is pretty similar to what I talked about. Daycare program, very helpful. We're very proud of our daycare. But equally, it's a level 4 evidence, which it's a bit like a case series. So we need to develop more evidence to justify the continuation of certain interventions. Even many, many years after the injury, there will be still a case to continue some sort of rehabilitation, either in the community, or patient's home. And usually there is a bit of formal rehabilitation that we do as clinicians, but also there's informal rehabilitation that families will do. Again, vocational rehabilitation, people who are most significantly worse cognitively, they will benefit most. Okay, I'll just say a couple of words because we have a dedicated talk from Eva about the families and how they cope with the illness. But just I thought I'll say a few words again as an introduction to Dave, which who I'm really grateful to for him to be with us today. ABI in the family. People talk now about brain injured families as opposed to brain injured individuals. So you go through this, which is a bit like a grief reaction. You hope that your relative will survive. This is stage 1. And then you hope that everything is fine. You think that's it. They were through the woods, everything is fine. And then stage 3, you start realizing that the progress isn't that good. And this is the stage where families are angry. It's a bit like here as well. But this is usually angry with professionals and with the system because we thought you can help my father and now he's still disabled. Nothing is happening. Stage 4, you start to realize and get depressed that over what's happening and the loss that you're going through, and hopefully you'll accept it at some point. The most distressing aspects, I talked about this already, people caring for somebody with brain injury will be at a high risk of developing mental illness. Especially spouses, very, very difficult position because you can't cope with your partner, but you can't leave them either. You feel guilty, but you are not literally coping. You can't do it. You can't leave because the families and friends wouldn't approve this, but equally, you're struggling. Children can be trapped between the injured parent and the depressed parent, or the parent who is dedicated to the injured parent, and educationally they may suffer. And there's a wide range of needs that families will need to address and will need to help them with. Okay, what we talked about was the brain and its injuries, and I talked about some important facts. Talked about some common causes and clinical presentation of injuries, and some evidence of management in different settings, and I touched on the family, the impact on the families. Some references, you'll get the slides anyway, so some references and further readings. And thank you very much for your attention. Thank you.